Hello, everyone. Today we're going to be talking about substance use disorder. This is for the Psychiatric Mental Health Nurse Practitioner exam. So substance use disorder is characterized by a pattern of use leading to clinically significant impairment of distress as manifested by two or more of the following symptoms within 12 months. So they have to have two of these: increased consumption of large amounts over a long period of time, a persistent desire or unsuccessful attempts to cut down, significant time spent in activities necessary to obtain, use, or recover from the effects of substances, cravings or strong desires for substances, recurrent use of these substances resulting in failure to fulfill major role obligations such as work, school, or home, continue use despite persistent or recurrent social or interpersonal problems. Important social, occupational, or recreational activities are stopped or reduced due to the substance use, and recurrent substance use in situations in which it is physically hazardous, persistent substance use despite knowledge of having persistent or recurrent physical or psychological problems that are likely caused by or exacerbated by the substance, and tolerance will develop. So terms, when we talk about dependence, that is the repeated use of a substance with or without physical dependence. Abuse is use that is inconsistent with socially used patterns. Misuse usually applies to a prescribed substance. Intoxication is a reversible syndrome caused by a specific substance affecting memory, judgment, behavior, or social or occupational functioning. Withdrawal is the substance-specific symptoms that occur after stopping or reducing the use, potentially not reversible. Tolerance, needing more of the substance to get the desired effect. Addiction is the persistent or increased use of a substance or behavior that, if it was discontinued, would cause distress and an urge to resume use despite related adverse consequences. Dependence are repeated use of a substance for physical need, leading to increased tolerance, and when discontinued, results in physical withdrawal. Abuse is the use of any substance that is derived from the approved social or medical practice. Codependence is the learned behavior pattern characterized by enabling maladaptive coping motivated by fear of losing the relationship, usually seen in family members of the identified patient. Neuroadaptive is a physiological process caused by physical changes in the body due to repeated exposure to a substance. Cross-tolerance is the process in which one drug can be substituted for another to produce the same physiological and psychological effects. So, for example, benzodiazepines and phenobarbital. And dual diagnosis, the co-occurring of substance use and psychiatric disorders. So when we talk about substance use, it's important to understand the different neurotransmitters in our body. So here are a bunch of neurotransmitters that are in our body, but which ones relate to which substances? When we talk about treatments, we can look at medications that also target those same substances. So for example, dopamine, this is our pleasure neurotransmitter. And when we talk about opioids, opioids actually signal the brain to release more dopamine, and over time it creates a reward pathway. So that's why people use opioids. They feel a lot of pleasure, and there's actually a reward pathway that gets created in their brain that kind of makes them want to use more because they feel this reward feeling. GABA is a calming neurotransmitter. It plays a role with alcohol and benzodiazepines. Glutamate also is our memory neurotransmitter. It's also kind of a stimulating neurotransmitter. We like to think of it as like the on switch where GABA is the off switch. They kind of work in parallel to one another. So glutamate also plays a role with alcohol and benzodiazepines. And then endorphins, these are the euphoria neurotransmitters, and we see that triggered with opioids. So substance use disorder is considered a neurobiological disease of the brain. The reward pathway in the brain when people are using opioids is actually hijacked, and it impacts their decision-making, emotions, and coordination. Brain-based changes in structures and function can lead to addictive behavior. And it's reinforced because there is a feel-good sensation, that reward sensation, those endorphins and that dopamine when the drug is used, and a feel-bad kind of sensation when the drug exits the body. The system is responsible for associating the stimulus of the substance with a reward pleasure, and it stores the learned experience in the memory. And we're going to talk more about that later. Sometimes unconscious cravings to re-experience the effect of the drug can occur during recovery when environmental triggers signal the memory center. So when we talk about brain reward systems, the mesolimbic dopamine circuit is the reward pathway in the brain, and it's activated in an individual response to natural rewards. So things like good food, intercourse, social interactions, all of these can kind of trigger that reward pathway. However, like we just talked about, opioids hijack that reward pathway. Other brain regions that are involved, there is a memory component when it comes to opioids and other substances, that it makes people want to repeat that behavior to feel that reward. There's other brain regions involved, including the VTA, which is the site of dopaminergic neurons, the ventral striatum, the target of the VTA dopaminergic neurons, the amygdala, which connects experience with emotion, and this is where conditioned learning happens. The hippocampus establishes memory of the drug experience. The frontal region, the prefrontal cortex, anterior cingulate cortex, and orbitofrontal cortex, executive control and choices, the hypothalamus, which coordinates brain function and physiological needs, and the locus coeruleus, where norepinephrine neurons are, and the dorsal raphe, where serotonin neurons are, which regulate mood and activation. So for the exam, you are going to need to know the parts of the brain where those neurons are kind of focused. So locus coeruleus is the norepinephrine, and the way I remember this is, to me, locus coeruleus sounds like a leader, like Napoleon, like fighting wars and stuff. I don't know why I think of this. I think it's because the name is like coeruleus, like they want to rule. So then I think of war, and norepinephrine is like the fight or flight. And then you want to remember that dopamine is made in the VTA. And you also want to remember that the dorsal raphe is where serotonin is made. So what's happening in the brain? The positive reinforcement is dopamine mediated in the ventral tegmental area and the nucleus accumbens in the brain. The neuropeptides trigger the dopamine release, which further reduces the perception of effort needed to use the substance. Neuropeptides further enhance the reinforced pleasure experienced by the person. The dopamine receptors become increasingly sensitive with continued and increased use, and eventually a similar release can occur with visualizing related paraphernalia. So they don't even have to be using it, they just have to see it. The negative reinforcement, which is called aversive driving, are gamma aminobutyric acid mediated triggered symptoms of dysphoria and anxiety. So they're going to have these feelings of dysphoria and anxiety when they are not using the substance. When it comes to brain reward systems, the brain-based changes in structure and function can lead to tolerance and withdrawal. Drug-specific alterations in the normal level of functioning and neurotransmitters occur as the body adapts to the chronic presence of the substance. Neuroadaptive processes become very significant when the person stops the substance use, and these processes become the basis of withdrawal symptoms because the adaptive response are unopposed when the substance is no longer present. And neuroadaptive changes may be more enduring in some people, possibly lasting for years, thus increasing their potential for relapse. So when we talk about the memory of drugs, so these are two brains. One is a person that doesn't have substance use disorder, and somebody who has substance use disorder. So the slide demonstrates how the mention of items associated, This is the same brain. The first one, they're showing them a nature video, and the second one, they're showing them a video of cocaine. And this is somebody who has active substance use or recovering substance use disorder. And pretty much what we can see is that when they're watching a video of nature, nothing is happening in the amygdala. However, when they see a video of cocaine, we can see the amygdala lit up. And like we talked about earlier, the amygdala is the center for memories. All right, so rules of neurotransmission. We have to remember what goes down must come up and what goes up must come down. So when individuals take something like a depressant, like a benzodiazepine, alcohol, or opioid, when they're intoxicated, they're quite sedated. However, when they're withdrawing, it's going to swing the other way. So they're going to be agitated, anxious, trembling, shaking, vomiting. They can have hallucinations. They can have seizures. Opioids, they're not as likely to have a seizure. They're going to feel like they're going to die, but they're not necessarily going to die usually unless there's some underlying medical condition. However, benzodiazepine and alcohol withdrawal, they can die. So when we talk about neurotransmitters, they are not easily fooled. They use two mechanisms to maintain homeostasis in the body. So the first is upregulation and the second is downregulation. So with upregulation, if the drug that is given decreases the neurotransmitters, so those little yellow dots, what's going to happen is that the synapse is going to add more receptors. This is fine and works for the body. However, when you take away that medication that is no longer decreasing those neurotransmitters, now the synapse is way too overstimulated because there's been an increase in neurotransmitters. Downregulation is the opposite. So if you take a substance that is increasing the neurotransmitters, the synapse is going to have less receptors to maintain that homeostasis, which works fine while they're taking the drug. But when the drug is no longer being taken, then the the synapse is not being stimulated enough because there is not as many receptors as there once was. And this is what leads to tolerance and withdrawal. So theories of substance use, there is the psychodynamic theory. We know that this is Sigmund Freud's theory, as we've talked in previous lectures. So behaviors of abuse are seated in the oral stage fixation. A person seeks gratification through oral behaviors. Maladaptive regressive behaviors can become overlearned, fixed, and reinforced through dysfunctional family patterns. And sociocultural factors attempt to explain population-based differences in substance abuse rates. So the second theory is the biological theory. People with strong genetic vulnerability to addiction are thought to have defects in the working of the reward system of the brain, which predisposes them to stronger than normal positive rewards that draw from the substance use. It's more common in males than females. Patients with first-degree relatives who have a substance use disorder are more likely to have substance use disorders. There are some ethnic differences. The highest rates of alcohol use disorder are seen in individuals of Hispanic, First Nation Americans, and African Americans. A person is predisposed to stronger than normal negative rewards, making it more difficult to stop the abuse once it's begun. Incidence and demographics. So people 18 to 24 have the highest rates for substance use disorder. And the United States has higher rates of substance use disorder than other countries. More than 50% of United States clients with a psychiatric disorder have a comorbid substance use disorder. Those with schizophrenia are 4 times more likely to have a substance use disorder, and those with bipolar disorder are 5 times more likely to have a substance use disorder. More than 2 million admissions annually are made to inpatient substance use treatment facilities. Though now legal in some states, marijuana is the most commonly abused illegal substance. So when we talk about stigma, what is stigma? It distinguishes and labels something as different. It connects it to undesirable characteristics. It generates an us and them representation, leading to social distancing. And it creates a loss of status, discriminates, bias, and has unequal outcomes. So when we talk about alcohol use disorder, alcohol is one of the most commonly abused legal substance. It is the most commonly abused legal substance. Rates are higher in men than women. 90% of men have used alcohol in their life and 70% of women. Rates for alcohol use disorder are higher in African Americans, Hispanics, and Native Americans, and they are the lowest in Asian Americans. 55% of fatal driving incidents in the United States occur with a driver under the influence of alcohol, and 50% of crimes in the United States are committed under the influence of alcohol, and the lifetime risk for alcohol use disorder is 15% in the United States. So some signs that we can look for with alcohol use disorder. So palmar erythema. So when you try to blanch the center of the palm, it only stays red. So like when you push on the palm, it should go white and then turn to red, but they won't have that. Telangiectasia, not exactly sure how to say, but hemorrhages on the lips. You can see an example of it over on the side. And Dupuytren's contractures, you can see that in the hand picture on the slide as well. Laboratory findings that suggest alcohol use disorder, so mild macrocytosis, elevated liver enzymes, elevated GGT, and carbohydrate deficient transferrin. Those can be some that we can see in labs. So how does alcohol affect the central nervous system? So it's a toxic substance that affects the brain by altering the balance of neurotransmitters GABA and glutamate. So it is a depressant. A lot of people think that alcohol is an upper, and it's because it disinhibits people. It makes you do things you wouldn't normally do if you weren't under the influence. However, it actually is a depressant on the central nervous system. So GABA, we like to think of as our off switch. It is what calms us down. It puts us to sleep. And glutamate is an excitatory neurotransmitter, and it speeds up or activates brain activity. GABA and glutamate are kind of on this teeter-totter together. If one goes up, the other goes down. And homeostasis through these neurotransmitters are when they are in balance. So they are on and off switch. We talked about GABA, glutamate. Okay. So as a result of chronic alcohol use, the brain adapts by down-regulating GABA and up-regulating glutamate. So we talked about that earlier. So as you can see, because alcohol sort of acts on the brain like GABA, it is causing the actual amount of GABA in the brain to decrease. And then in order to equal out, it is increasing the level of glutamate. And we talked about tolerance versus dependence. So when people are in a withdrawal state from alcohol or benzos, it can be life-threatening. When they chronically use alcohol, the result is withdrawal symptoms if they stop using it. Withdrawal can result from excessive glutamate activity in the absence of alcohol. And the increased excitability of the brain in autonomic arousal, they can have hallucinations, be sweating, nausea, vomiting, tremors, confusion, agitation, and delirium tremens. Some individuals can experience withdrawal symptoms even with an elevated blood alcohol level because their body is so used to it being so much higher. So as we can see, if you take the alcohol away, what happens is we have too little glutamate or too little GABA and too much glutamate. And glutamate is excitatory. So that's where those seizures are coming from, the tremors, sweating, all of those signs and symptoms of withdrawal. So here's kind of an overview of everything that we talked about in one nice little slide. So homeostasis, non-person using alcohol, the GABA and glutamate is equal. When intoxication occurs with the occasional user, GABA goes down and glutamate goes up. The person feels kind of sedated, right? How you feel when you're, drunk or intoxicated. With chronic and regular use, what happens is the body creates the homeostasis. So now the body has upregulated the glutamate. So it has added way more receptors to overstimulate that glutamate because we have GABA with the alcohol. So it needs to even out. But what happens is when they are withdrawing, GABA, there is not enough of it and there's too much glutamate. And then we have those signs and symptoms of withdrawal. So we also want to note, what is an alcoholic drink? So like one time I had a patient say to me, I have one drink a night. And I say, oh, well, how big is the drink? Explain to me what it looks like. And he goes, one full glass, pretty big glass, but one full glass. And I was like, oh, well, what are you drinking? And he was like, whiskey. Well, that's not one drink, right? One drink of whiskey is 1.5 fluid ounces. So if a person is even drinking one full cup, which is 8 fluid ounces, that is the equivalent of 6 drinks. And this cup he was talking about was probably 2 cups. So it's like 12 to 16 drinks. You know what I mean? So you have to know what type. So for example, 12 fluid ounces of a regular beer is 1 drink, 8 to 9 fluid ounces of malt liquor, 5 ounces of table wine, or 1.5 fluid ounces of whiskey, gin, rum, vodka, and tequila. Those are all 1 drink. So long-term effects of alcohol. So neurological can lead to dementia, stroke, neuropathy, myopathy, epilepsy. They can have cardiovascular things like hypertension, coronary artery disease, cardiomyopathy. Gastrointestinally, they can have cirrhosis, gastritis, alcoholic hepatitis, GI bleed, esophageal varices, poor absorption of nutrients. Psychiatrically, they can have depression, anxiety, even self-harm. Neoplasm, bunch of different ones there, and fetal alcohol syndrome can happen if people are drinking while they are pregnant. Timing of alcohol withdrawal syndrome. So minor withdrawal is going to start 6 to 36 hours after the last drink. They can have tremulous, anxiety, headache, diaphoresis. Seizures, we have to start looking for between 6 to 48 hours. Alcoholic hallucinations, 12 to 48 hours after. And delirium tremens is pretty much a mixture of delirium and alcohol withdrawal, and that typically happens 48 hours to 96 hours after the last drink. So when alcohol intake is abruptly stopped, the body does not have enough time to adjust to GABA and glutamate regulation, and it results in alcohol withdrawal syndromes or symptoms. Alcohol withdrawal symptoms begin to manifest around 8 hours after the last drink and peak between 24 to 72 hours. So you can see here the common signs and symptoms of alcohol withdrawal. We kind of talked about some of those. We talked about minor withdrawal versus moderate, and then that delirium tremens, severe alcohol withdrawal with delirium or an altered mental state. Predictors of if people are going to have DTs is if their CWA is greater than 15, they've had recent withdrawal seizures, they have a history of DTs or withdrawal seizures, they have metabolic issues, or they are older in age. And again, this is a nice chart. I love charts. So of the timeline of alcohol withdrawal. So for benzodiazepine withdrawal, it is going to depend on the benzodiazepine that is being used. And again, this can be for people who are misusing benzodiazepines, but it can also be somebody who's been prescribed them for a very long time and they're trying to get off of them. So we have short, medium, and long acting, and depending on the half-life is when you're going to start to see symptoms. Some of the symptoms we will see are neurological and physical complications. So they can have, if they abruptly stop, they can have increased risk of seizures, impaired voluntary movements, cognitive impairments, problems with memory, photophobia, hypersomnia, trembling, sweating, nausea, vomiting, motor agitation, elevated blood pressure, very similar to what we talked about with alcohol withdrawal. They're actually very similar. We use for both alcohol and benzodiazepines the Clinical Institute Withdrawal Assessment, or a CIWA. There's a CIWA-AR, which is the alcohol revised, and then there's a CIWA for benzodiazepines. Typically, we want to medicate anything over a CIWA of 8. 0 to 8 is mild, 9 to 15 is moderate, and then anything greater than that is severe, and the maximum scores is 67. So there are scores in 10 areas. We look at nausea, vomiting, anxiety, sweating, tactile disturbances, visual disturbances, tremors, agitation, orientation, auditory, and headaches. We also take vital signs. Sometimes it's good to ask people, what are the symptoms you're experiencing, and not necessarily ask directly or tell me how you're feeling, and then be able to fill out the assessment. It's really up to you the way you want to conduct it. You can also ask them, do you have a headache? Are you feeling anxious? You can ask them the specific questions as well. Okay. So treating alcohol withdrawal symptoms. So we know that GABA and glutamate are responsible. The American Society of Addiction Medicine Clinical Practice Guidelines recommends using benzodiazepines as the first-line treatment for both alcohol and benzodiazepine use disorder. Benzodiazepines are fully effective when GABA is available at the receptor site. Phenobarbital has a similar pharmacokinetics and is frequently used for alcohol withdrawal. Patients with alcohol use disorder, we know, have the downregulated GABA receptors. Sometimes this can lead to benzodiazepine resistance. And a patient with alcohol use disorder has lower levels of GABA, causing benzodiazepines to fail to produce the desired response, resulting in resistant alcohol withdrawal symptoms characterized by hallucinations, seizures, and delirium tremens. This happens in some people. It's not super common, but sometimes benzodiazepines don't work, but they are the first line. In those cases, we can use phenobarbital, which also acts on glutamate in addition to GABA. It has a robust response, unlike sometimes benzos don't work sometimes. So we can use phenobarbital, and it doesn't require endogenous GABA. So when we treat alcohol withdrawal symptoms, we always want to focus on alleviating symptoms. We like to have what we call comfort medications. So things like Tylenol for headache, Maalox for upset stomach, Zofran for nausea, just to help people be more comfortable as they go through this. We want to prevent progressive symptoms. So using those CWAs and medicating as needed to help them to not withdraw as much and kind of taper down. We can offer supportive care. So if they have a thiamine deficiency, we want to treat that. We want to be careful because they can have Wernicke's encephalopathy, partial or complete paralysis of the extraocular muscles, nystagmus, ataxia, and mental disturbances. It has a 10 to 20% mortality rate if untreated. And we treat this by using thiamine replacement. And then Kornikov's psychosis, we want to watch for that as well. So again, medications used to treat alcohol withdrawal, most commonly used is Ativan because it has a rapid onset of action and a shorter duration, which reduces the risk of oversedation. It's not metabolized by the liver into the active metabolite, and therefore it's safer in patients with hepatic dysfunction, which we can find quite often with alcohol use disorder, and can be administered parenterally or orally. We can also use Librium, diazepam as well. Phenobarbital we can also use, but we don't use lorazepam and phenobarbital together. When using phenobarbital, it acts, as we talked about, on glutamate and GABA. It allows, its pharmacology allows it to be loaded rather than up titrated gradually, so we can kind of give them a big dose at the beginning. It provides predictive drug levels, very long half-life. It affects GABA receptors and inhibits glutamate receptors. We can check levels to see how high it is in the body. It has a long half-life, so you can see that there. And patients should be monitored for adverse effects such as oversedation and respiratory compromise. So nurses can support patients going through alcohol withdrawal by doing a CWA every 4 hours, medicating them as needed, waking them up overnight to medicate them. If they're on a Q4-hour CWA, we should wake them up to medicate them. Because if not, when they wake up in the morning, they're probably going to be very uncomfortable and be withdrawing. And then alcohol use disorder with pregnancy. This can lead to fetal alcohol syndrome. 1/3 of all infants born to females with alcohol use disorder have fetal alcohol syndrome. They can also have birth defects, low birth weight, short palpable fissures, mid-face hypoplasia, etc. These are all kind of the signs. They can have coma, respiratory depression, and death. So the ASMAth, this is the Short Michigan Alcohol Screening Test. It is 13 questions answered. A yes gives you 1 point, no is 0. 0 to 2, no problems reported. 3 is borderline alcohol problem, must be investigated further. And 4 or more is potential alcohol use disorder. The CRAFT screen, this is a 6-item CRAFT. So mnemonic is car, relax, alone, forget, friends, and trouble. It is a brief questionnaire for adolescents to screen for alcohol use. 1 point for each yes, and a score of 2 or more needs further investigation. So the Audit C is an alcohol risk assessment. So all of these are like screens. It helps you to identify if there could potentially be an alcohol misuse disorder. So these are 3 questions that we ask people to identify those at risk of being hazardous drinkers. Early identification improves health outcomes. So a 4 or more in men is a positive screen, 3 or more in women, and that is an example of the audit C. The CAGE alcohol use questionnaire, and again, we're going to go over the screening tools that you need to know in our screening lecture, the screening tool lecture, or assessments, scales, but these are just a review of some of them. So the CAGE is alcohol use questionnaire, has 4 questions. So have you ever felt you should cut down your drinking? Has anyone been annoyed or criticized your drinking? Have you felt guilty about your drinking? And have you ever had an eye opener or a drink first thing in the morning to steady your nerves? At 2 or more, indicates that there is a potential drinking issue. Physical findings related to alcohol use, they can have mood changes, behavior changes, poor oral health, cardiovascular, gastrointestinal, neurologic issues, and metabolic issues. And we talked about this a little bit earlier. So alcohol use laboratory indicators. So usually their liver enzymes are going to be elevated. MCV is going to be elevated. PT is going to be increased. They might have hyponatremia or hyperkalemia. Usually their total cholesterol and triglycerides are elevated. Their amylase is elevated. Obviously blood alcohol level. So those are some of the things that we can see. So pharmacology for alcohol abstinence. So the first is something called Campril or Camprosate. This is a first-line medication for post-withdrawal maintenance. So after people have withdrawn off of the substances, these are the medications that we can use to sort of like the medication-assisted treatment. They're medications that can be used to help people to stay in sobriety. So it's believed to restore chemical balance in the brain that is disrupted by long-term alcohol use. Usually 2 333 milligram delayed release tablets by mouth 3 times a day with or without food. They're swallowed whole, not crushed or broken, and usually start 5 days after alcohol use, and they can take 5 to 8 days to see effects. The most common side effect is diarrhea, and women should have an effective birth control method when taking Campril. It doesn't interact with alcohol or other drugs. It just sort of helps take away cravings for people. Naltrexone is the other first-line medication used for post-withdrawal maintenance of alcohol use disorder. It was first made to combat opioid addiction, but then it was found to help reduce alcohol consumption. Naltrexone blockade persists for 48 to 72 hours after the last dose. We start with 25 milligrams a day and move up to a maintenance dose of 50. It does not interact with alcohol and does not have addictive potential. And it also has an intramuscular version called Vivitrol, which is a once-a-month injection. Naltrexone is contraindicated in individuals taking or likely to take opioids. And then we have Antabuse. So this is a second-line medication, and that's because it can make people feel horrible if they consume alcohol, which doesn't even have to be an alcoholic drink. It can be things like perfumes, mouthwash, hand sanitizers, hairsprays, aftershave, just products that contain alcohol. So what it does is if a patient drinks alcohol or somehow ingests some type of alcohol, it's going to make them feel physically sick. They're going to get flushing, nausea, vomiting, tachycardia, hypotension, dizziness, headache. So it will begin working shortly after taking it and will continue to work for 1 to 2 weeks after the last dose. So you have to, if people are taking this and they want to come off of it, they need to know they still cannot consume alcohol. And that can be things like vinegars or kombucha or sauces for another 2 weeks. So now let's move on to opioid withdrawal. So when we talk about opioid withdrawal, it's typically not life-threatening, although they're going to feel like they're going to die. Except for people with co-occurring health issues like cardiovascular disease or newborns. Withdrawal symptoms will vary depending on the drug of choice. Faster onset means faster half-life. So for example, heroin or fentanyl withdrawal will start 6 to 12 hours after the last dose, whereas methadone withdrawal, which is a much longer acting, will start 12 to 48 hours after the last dose. Clinical Opioid Withdrawal Scale, or the COWS, is what we use to assess for signs and symptoms of opioid withdrawal. So a 5 to 12 is mild, a 13 to 24 is moderate, 25 to 36 is moderately severe, and anything over 36 is severe. So things that we look at, it's an 11-item scale. We look at resting pulse, sweating, restlessness, pupil size, bone and joint aches, runny nose, GI upset, tremors, yawning, anxiety, irritability, and goose flesh skin, or like goosebumps on the skin. The timeline, again, it depends. If it's a short acting like fentanyl or heroin, we're going to start to see symptoms 6 to 12 hours after. Or if it's something like methadone, which is longer acting, we're going to start to see symptoms around 30 hours later. And a peak of symptoms will happen in 72 hours: nausea, vomiting, stomach cramps, diarrhea, depression, drug cravings, and that's why having comfort meds is really important, because we can treat the nausea and vomiting with Zofran. We can treat the diarrhea with Maalox, different things like that. So medications used for opioid withdrawal. So we can use methadone, which is a full agonist. As you can see, the receptor there, it fits in like a lock into a key. It's a perfect fit. And again, it's long acting. We can also use something called buprenorphine or Suboxone. This is a partial agonist. So as you can see, those are the yellow dots. It fits in, but it's an imperfect fit. So it doesn't stimulate the receptor 100%. It only stimulates it partially. The imperfect fit in the receptor allows it to slowly dissipate 24 to 72 hours while blocking other opioids from attaching. Buprenorphine comes in other preparations, such as a sublingual film, or there is an injectable version as well. When we treat withdrawal symptoms, so we talked about you can use methadone, you can use buprenorphine. We also use clonidine, which is an alpha-2 adrenergic agent. It helps manage that autonomic dysregulation seen with withdrawal, but we have to monitor for hypotension. And then we talked about PRNs that can be used. So a partial agonist does not have respiratory depression, has a limit on analgesia, prevents opioid withdrawal, and blocks full agonist. So we can see Suboxone is the partial agonist there. It has a ceiling effect. So it stimulates that receptor, but only to a certain point, and then it levels out. An antagonist is something like naltrexone or Vivitrol. It has no opioid activity, and it actually blocks the opioids from being able to attach to the receptor. And it can reverse overdoses. All right, so we talked about methadone. We talked about Suboxone. One of the big things from this, from a nursing standpoint, is you want to stay with the patient while it dissolves for 5 to 10 minutes. And you also, if it's the first dose of Suboxone, they haven't been on it before, they've been using medication, using substances outside the hospital, opioids specifically, the first dose of Suboxone, you want to make sure that their COWS score is greater than an 8. If not, you will throw them into a precipitated withdrawal. So they will have withdrawal symptoms very quickly, because what is going to happen is that Suboxone, which is these little yellow circles, will come into where that full agonist is and pop it off of the receptor because it has a higher affinity to the receptor. There's more magnetism between Suboxone and the opioid receptor than with full agonist opioids. Sublocade is the injectable extended release version. It is given in the abdomen. You can see it in the picture there every month, and it rotates spots on the abdomen. And it's a subcutaneous injection, which is nice. It's not deep. It does sting. Sometimes you can put a numbing cream down before giving the injection. Naltrexone, this is Vivitrol, which we talked about, or Revia is the oral version. And we already kind of talked about this for alcohol use disorder, but it is also used for opioid use disorder. We have to make sure people have not been using opioids for 7 to 14 days before giving this medication. And it is given in the ventral gluteal site, as you can see in that picture, and it is a deep intramuscular injection. We talked about Vivitrol. Prior to administering, we talked about you want to make sure that they're 7 to 10 days off of opioid medications, not approved in pregnant women, not approved in children. So it's really just adults who aren't pregnant. All right. So pain management for people actively using opioids. So there is a condition called hyperanalgesia, which occurs with chronic opioid use, which lowers the pain threshold and pain tolerance. So they have a lower pain tolerance. They typically do need more pain medications than people who do not have chronic opioid use disorder. We can always, depending on where your facility is, but you can always consult with addiction services as well. They can be particularly helpful. So substance use physical assessment, we're going to see, mental status exam changes depending if they are intoxicated or withdrawing from the substance. It depends on the substance. So stimulants, we might see agitation, restlessness, irritability. Depressions, we might see euphoria, impaired attention, impaired memory. Hallucinogenics, we can see mood swings, pain, aggressions, paranoia. Cannabis, we can see paranoia, confusion, and disorientation. Inhalants, we can see irritability, delirium, confusion. In their eyes, we can see icterus, which is due to liver failure. Nystagmus is seen in opioid use disorder, and same with the pinpoint pupils. So again, these are just some of the physical findings that we can see. I'm not going to read through them all. Criteria needed to identify a substance use disorder. So maladaptive patterns of use co-occurring for at least a 12-month period of sustained use. It must be accompanied by repeated failure to fulfill major role obligations, must be accompanied by use in a situation that presents as physically hazardous, such as drinking and driving, and abuse continues despite problems such as legal, interpersonal, and social problems. We're going to see things like patterns of using, tolerance, withdrawal, large amounts needed to be ingested, persistent cravings, large amounts of time spent obtaining the substance, activities decrease or given up because of use despite consequences, and psychological dependence. And we went over those mental status exam findings. And we went over pharmacological management as just a re-summary. Alcohol, we're typically using lorazepam. If that doesn't work, we can use phenobarbital. For polytherapy, we can, use SSRIs, opioid antagonists, and NDMA agonists. Sometimes anti-seizure medications are used to decrease the potential of seizures, and adrenergic medications are used to decrease blood pressure and heart rate associated with withdrawal, which we talked about as well. This is a nice chart. I like charts. So medication-assisted treatment for addiction. This is just a chart of some of the options. So citalopram is an SSRI that reduces the desire for substance enjoyment. Bupropion can also be used to reduce cravings and withdrawal intensity. Ondansetron has been found to help with cravings as well. Naltrexone reverses opioid sedation, or naloxone, Naltrexone has longer acting, reduces cravings. Buprenorphine we talked about, methadone we talked about, acamprosate, and we talked about all that. All right, so a lot of these we talked about. So just to go back to disulfiram, we don't want to administer unless a person has been alcohol free for 12 hours is the one that's going to make them sick. And they have to, again, be off of it for 2 weeks before ingesting anything with alcohol. That's important to know for the exam. Non-pharmacological treatments, so multimodality treatment, lifetime treatment is usually needed. They can get inpatient treatment, especially for detoxification and withdrawal safely. And sometimes making sure that they're in a quiet environment can be helpful for the central nervous stimulation that can be observed when people are going through withdrawal. We want to make sure we maintain hydration. We want to have a plan for follow-up care, make sure they have supports in the community, whether it's a 12-step support group or psychotherapy, and identify a primary healthcare provider. Recovery programs typically include counseling to help them develop positive coping skills and positive life skills, and also medications to target the limbic region to treat the physical effects of addiction. The neurotransmitter dopamine is thought to be responsible for repeating behaviors that are pleasurable. In recovery, a person must experience various triggers or cues that lead to a dopamine surge. This powerful surge can cause the person to use the substances again. There are medical problems that can occur that require further evaluation and potential treatment. So there can be neurological issues, cardiovascular, nutritional, gastrointestinal issues. So, things that we can give them are things like halfway house, 12-step programs, Alcohol Anonymous programs, help them to figure out how to manage guilt and anger feelings, refer to community resources, all of these types of things. Lifespan considerations. So children and adolescents, this is typically the period that substance use starts, has due to peer pressure. 30 to 40% of adolescents report drinking frequently, 15% report binge drinking, and 50% of high school age student reports at least a one-time use of illicit drugs. Older adults, we might need to give them large print educational material. They might need to be referred to a specialist to help them deal with losses. They will do better if they're treated in the same age group. Transportation may be an issue for them, and adaptations to their home environment may help them to cope with their physical disabilities. And that is the end. Thank you so much. I'll see you next time. Bye.